Welcome to this educational presentation from Professor Mohammadi's Teaching Archives. Today, we will review a practical and safety-focused approach to childhood headaches, with special attention to common pitfalls that can lead either to missed serious diagnoses or to unnecessary testing. Headache is very common in children and adolescents, and fortunately, many cases are benign. However, the key clinical responsibility is to avoid becoming too comfortable with common explanations too early. A systematic approach helps us recognize when a headache pattern is typical and reassuring, and when it deserves closer attention. Throughout this presentation, we will focus on history, examination, red flags, appropriate investigation, and reassessment over time as essential safeguards in pediatric headache care. The central challenge in childhood headache assessment is finding the right balance between vigilance and restraint. On one side, we do not want to dismiss a serious secondary cause as a simple migraine. On the other side, we also do not want to image every child unnecessarily, especially when the history is typical, the examination is normal, and no red flags are present. Good clinical decision-making depends on recognizing subtle clues, understanding the pattern over time, and using reassessment as part of the diagnostic process. Red flags help guide urgency, but clinical judgment remains essential. Next slide, please. One common pitfall is assuming that every recurrent or severe headache in a child is migraine. Migraine is certainly common in childhood, but it should not become an automatic label. Secondary causes may sometimes present with headache as the only symptom, or as an early symptom before other neurological signs become obvious. A migraine diagnosis is most secure when the history is typical, the neurological examination is normal, and the pattern is stable over time. However, when the headache is new, atypical, progressive, or associated with red flags, the clinician should pause and deliberately broaden the differential diagnosis. Possible missed causes may include brain tumor, raised intracranial pressure, infection, vascular disorders, or metabolic disease. The safest approach is to take a complete history, examine carefully, assess red flags, and keep the differential diagnosis open. Next slide, please. Another important pitfall is failing to examine the fundus. Papilledema can be a critical clue to raised intracranial pressure. If it is missed, diagnosis may be delayed, especially in conditions such as brain tumor, hydrocephalus, venous sinus thrombosis, or pseudotumor cerebri. Fundus examination remains a high-value bedside skill. It should be considered especially in children with persistent, recurrent, progressive, or otherwise concerning headaches. It is also important to document the finding clearly. If the optic discs were visualized, say so. If papilledema is suspected or cannot be confidently excluded in a concerning case, further evaluation or referral may be needed. The next pitfall is the opposite problem: excessive imaging in children with uncomplicated migraine. Imaging can be very useful when red flags are present or the examination is abnormal. However, routine imaging for typical migraine with a normal neurological examination can cause harm. It may increase cost, expose children to radiation when CT is used, and create anxiety through incidental findings. Incidental abnormalities may not be related to the child's headache, but they can still lead to overdiagnosis, repeated testing, and unnecessary worry for families. The key is to follow evidence-informed imaging decisions. Image when the clinical picture supports it. When imaging is needed, MRI is usually preferred over CT unless an urgent situation requires a different approach. Next slide, please. A progressive headache pattern should never be ignored. Sometimes the most important clue is not the severity of the headache on a single day, but the direction in which the pattern is moving. A headache that is becoming more frequent, more severe, occurring at unusual times, or changing in character over weeks to months, deserves careful reassessment. This pattern may be an early sign of serious disease, including a space-occupying lesion, chronic subdural hematoma, hydrocephalus, or central nervous system infection. Clinicians should ask specifically about duration and trend. A headache diary can be very useful, especially when the history is unclear or symptoms fluctuate. Planned follow-up and clear return precautions are essential when uncertainty remains. Next slide, please. Another easily missed issue is hypertension. Blood pressure measurement is simple, fast, and highly informative, yet it may be overlooked during headache assessment. In children, hypertension can itself cause headache, but it may also signal an underlying renal, endocrine, intracranial, or other systemic disorder. Importantly, pediatric blood pressure should not be interpreted using adult thresholds alone. It must be compared with age, sex, and height percentiles. For this reason, blood pressure should be measured at every visit in a child presenting with headache. If elevated blood pressure is confirmed, the clinician should consider secondary causes and manage or refer the child appropriately. Red flags are practical warning signs that should increase clinical concern and guide the urgency of evaluation. Important red flags include early morning headache, headache that wakes the child from sleep, vomiting, especially in the morning or projectile vomiting, papilledema, progressive worsening, or a clear change in headache pattern. Other concerning features include focal neurological deficits, seizures, altered consciousness, confusion, ataxia, gait changes, systemic symptoms such as fever or weight loss, and headache after head injury. A red flag does not automatically define the diagnosis. However, it should prevent premature reassurance and should prompt more careful examination, follow-up, and investigation when appropriate. Next slide, please. The golden principle is simple. When in doubt, think wide, examine carefully, and reassess over time. Safe pediatric headache care is not about ordering every possible test. It is also not about relying too quickly on the most common diagnosis. The safest approach lies between these extremes. A systematic assessment, attention to red flags, thoughtful use of investigations, and planned reassessment can reduce both misdiagnoses and unnecessary testing. This is especially important in children because symptoms may be described indirectly by parents, and the full clinical pattern may become clear only after time has passed. Next slide, please. A practical workflow can help make headache assessment consistent and safe. Start with a careful history. Ask about onset, timing, triggers, associated symptoms, progression, family history, medication use, functional impact, and any recent trauma or systemic illness. Then complete the examination, including neurological examination, fundus examination when indicated, and blood pressure measurement. After that, identify red flags before deciding whether investigations are needed. Investigations should be appropriate to the level of concern. Finally, communicate the follow-up plan clearly. Reassessment is not just an administrative step, it is part of the diagnostic strategy. By repeating this sequence whenever the headache pattern changes or symptoms persist, clinicians can support better outcomes and safer care. Thank you for watching this presentation from Professor Mohammadi's teaching archives. The main message is that childhood headache assessment should be systematic, careful, and balanced. Most headaches are benign, but serious causes can be missed if red flags, examination findings, blood pressure, or progression over time are overlooked. A structured approach helps clinicians protect children from both delayed diagnosis and unnecessary testing.